Welcome to today's edition of Medically Speaking. Today I have two special guests with us from our Cancer Center. We have Dr. Ahmad Rahal and Dr. Clint Wood. In today's topic, we're going to be talking about our Cancer Center at Self Regional. These two physicians are specialists in their areas. Dr. Rahal is a medical oncologist and Dr. Clint Wood is a radiation oncologist. We're going to have a really interesting conversation today around cancer. What is cancer? What are the treatments that we offer at Self Regional? And some really neat things that I want the community to know a little bit more about. So I thought we'd just start a little bit more with some introductions. So Ahmad, maybe just tell us a little bit about your background to start with, kind of where you're from, where you did your training, and how you ended up in Greenwood.
Sure. So basically, I was born in Colombia, South America. And then after that, I moved to Lebanon. And I did my medical training there in Beirut. After that, I moved to the States, and about 10 years ago, in 2013, that's when I did my training in Kansas, in KU. I did my internal medicine training there. After that, I did my oncology fellowship in Houston, in Baylor College of Medicine. Then after that, I was looking for a job and looking around, and then one of the oncologists, Dr. Yen, which it's at Self Regional, I kind of contacted her, and she was very happy here, and then it worked out. We have some family around, and then decided to give it a try, and been here for 5 years, and everything is going well.
That's awesome. Yeah, so I believe Dr. Yen, did she also train at Baylor?
She did, yes. Yeah. I think that's how I knew about Self Regional, and then we decided to kind of, she was very happy here.
Yes.
And then Dr. Sedersky was here for a very long time, and that made kind of my decision kind of to come here, and then everything has been going well since then.
Awesome. Yeah, that's great. Baylor, great reputation, great training in medical oncology, and we're super glad that you're here at Self Regional.
Thank you.
Yeah, thank you. And Clint, tell us a little bit about yourself.
Okay, well, Columbia is a lot more interesting than where I'm from. I was born in a little town called Moorhead, Kentucky, which is in the Appalachian Mountains in eastern Kentucky. And all my family lives in the same county, and born and raised there. And my dad was in the Army, so we moved around quite a bit, but started in Kentucky, ended in Kentucky, and I'm a Kentucky boy all the way through, and especially when it's basketball season. But I went to the University of Kentucky Medical School, and prior to that, I'd gone to grad school at the University of Wisconsin in Madison, and I was studying radiation physics, and I really didn't know what I wanted to do with my life, but I knew a little bit of medicine, a little bit of physics, and radiation physics kind of fit the two of those, and I got about halfway through that and decided to go to medical school and take those skills and apply them to radiation oncology. And I did my residency at the Medical College of Wisconsin in Milwaukee.
Gotcha.
Wisconsin.
And how long have you been with Self now?
This is my 13th year.
Wow. Yeah, that's awesome. Great. Well, super glad to have this conversation today. I thought we would just maybe just talk a little bit about cancer in general. Maybe, Ahmad, we'll start with you. Just tell us, what is cancer exactly?
Sure. So I think it's a disease, basically. I think you have to look at it. It kind of, the cancer starts from our own cells. Okay. So normally when you have a normal cell, it has a specific age where that cell will have to die. So there is a specific program inside you that will tell that cell to die at a specific time. So there are specific mechanisms that happen for that cell to be able to die, and then new cells will form. Let's say when you shave you cut your hair or something, there's something growing back. So there's always that renewal that is going on. So what happens with cancer is that particular cell, when it becomes of age and is supposed to die, the mechanism that will let that cell die, it just doesn't work anymore. So that cell doesn't die anymore, and it just multiplies. And it starts growing and growing and becomes a tumor. And, there is always a mechanism for that. And it's usually, there are some genes, the genes that we're usually born with, they are that control that mechanism for the cell to be able to die. They just don't work. And that tumor starts growing and growing, and that's what's known as cancer. So it's basically a disease when there's an uncontrollable growth of your cells, where they multiply and they don't die anymore.
And so, there's, of course, different types of cancer, right? So, like,
Right.
if it was, like, in an organ, it might grow like a tumor. But, like, blood cancers also are a little bit different. Maybe talk about blood cancers for a little bit.
Right. So blood cancers are different in a way that you don't really see them on a scan, let's say.
Right.
Or sometimes you don't really feel them as a tumor growing in some place of your body, like, let's say. So they just run in the blood, and a lot of the times they come from the bone marrow. And they just go in the blood, and they multiply in the blood. So in this particular case, the mother cell in the bone marrow that's making those cells every day, it develops a mutation or something wrong in it. And instead of making a specific number of cells, it just multiplies and make millions of cells. And then it has to go out of the bone marrow to the blood. And, depending on what type of blood cancer you're talking about, it can grow in the lymph nodes, and that's sometimes when you can see the growth there. Or you're talking about leukemias, when people start becoming sick from the problems from that growth.
Thank you for that. That's good information. Clint, maybe for you, I know there's sometimes some confusion about, let's say, a diagnosis. Like someone hears, "Oh, I have stage 2 cancer, or I have stage 3 cancer, or I have stage 4 cancer." Could you just walk us through just the basics of what that means, like the staging of how cancers are staged?
Yeah, I'll try to. Staging of cancer is a way that we can classify or categorize the progress of the cancer. How far has it grown? What I like to tell my patients is really cancer comes down to 3 questions for me. And so we have to be able to answer 3 questions. And question number 1 is what you just asked, is what is it? What is this cancer? What is it called? Where did it come from? And question 2 is where is it? And the where is it question is the staging question. And so where did it originate? Has it invaded other structures? Has it spread into the lymph nodes? Has it metastasized or spread throughout the body? And the staging system typically goes from a stage 1 to a 4, with 1 being the most early stage and 4 meaning that the cancer has spread throughout the body. And so it's a way that we can categorize, and a way that we can also have different treatments that will apply to different stages of cancer. So stage 1s are typically the best and the most favorable. You've caught them the earliest, and the treatment may be different for a stage 1 versus a stage 2 or a stage 3. And then stage 4 is when we really rely on our medical oncology colleagues, when the cancer now has spread throughout the body, and the treatment has to be able to do the same thing, and that's where their therapies come into play.
Absolutely. So, of course, there's a lot of different treatments for cancers. I thought maybe you guys can touch on, what's the difference between like chemotherapy or radiation treatment or immunotherapy, or just those different types of cancer treatments, and like what are some factors that may make one cancer like better treated by one modality versus another?
Okay, sure. I think that's a very important question because, I think, and we have to be careful because let's just start with the basic chemotherapy. I think that's what most of the people are familiar with. So chemotherapy, think about it as a chemical. So it's a toxin that you put in your body, and then the idea of that chemotherapy is to work on anything that's multiplying fast. So as we talked earlier, the cancer, they grow very fast, and then the chemotherapy will go and try to kill anything that multiplies fast. The problem with chemotherapy, it doesn't really differentiate between a cancer cell and a normal cell. So when you give that toxin, you will have side effects because that chemo is intended to kill anything that multiplies fast. So you're talking about, for example, your hair cells, which multiply every day. The chemo can kill those hair cells. You can have hair loss. There are cells in your stomach and in your intestines that kind of multiply every day. So the chemotherapy can damage those cells, and that's why patients have nausea and vomiting. And you can have any rash or basically, and with many years ago, they didn't really know which chemotherapy will work for what type of cancer. So they tried different trials. For example, the colon cancer, they tried this type of chemo and it works, so that's how it's approved. And there are many types of chemotherapies. The other types of treatments, let's say there's immunotherapy. Immunotherapy is different than chemotherapy. Immunotherapy is an infusion, and it works by activating your own immune system. So it activates your own immune system to recognize the cancer. Because what has happened is that your immune system didn't really recognize the cancer to the point that the cancer has started growing inside you. And the immunotherapy will go in and try to prevent, so the way cancer works, it will put some brakes on the immune system. So the immunotherapy will break that brake and unleash that immune system. That way your immune system will be able to kind of recognize the cancer and attack it. So the problems with immunotherapy is that sometimes we can overactivate your immune system, and the immunotherapy will go ahead and attack your own body. And that's what we know as autoimmune disease. So when you have an overactive immune system, patients have autoimmune diseases. So if things like this happen, we usually treat side effects from immunotherapy by giving medications that suppress your immune system. Let's say prednisone or steroids. They basically are, they kind of calm your immune system down, and that's immunotherapy. So chemotherapy, it's a toxin. It doesn't differentiate between good and bad, and it tries to kill anything that's multiplying fast. Immunotherapy, it's an infusion that helps activate your immune system for your own immune system to fight the cancer. I'll let Clint talk about radiation, but there's one important treatment. It's called targeted therapy. Sometimes you see patients kind of get treatment for cancer with a pill. So what happens is, when we were talking in the beginning, I was talking about the cancer growth, and there's a problem in the gene. Sometimes it's not like the cancer cell is not dying. Sometimes there is a problem, a mutation in that gene that lets the cancer multiply very fast. So throughout the years, they have been able to kind of find specific medications that block that mutation. And when you block what's kind of triggering that cell to grow, you're basically killing the way, or stopping its growth, and the cancer will die. In order to be able to be a candidate for that treatment, it's called targeted therapy. So you really have to have that mutation. So nowadays, when most of the patients that have a cancer that is a stage 4, it has a spread, we kind of take that cancer and then send it for a DNA or analysis. So we try to look at that cell that was a normal cell and change to a cancer cell, look into what happened in that DNA. Once we find that mutation, we will go back and see if we have a pill that blocks that mutation. If that's the case, we usually try to treat it with that targeted therapy to that mutation and block that. There is another example. For example, you have breast cancer, where some of the cancers, they grow through estrogen. And we have pills that block the estrogen. In that case, you're targeting that estrogen receptor, which basically lets the cancer grow. And if you're doing that, basically you're targeting what is kind of making that cancer grow and multiply, and that's what we call targeted therapy. So in the medical oncology field, we talk about chemotherapy, immunotherapy, and targeted therapy. That's kind of big,
That's a good way to think about it. Kind of those three big categories of
yes.
medicines. Gotcha.
Definitely.
And Clint, maybe touch on radiation therapy a little bit, and like, how do you decide if someone needs that or not?
All right, so I'm glad you guys asked Dr. Rahal to come, because he just went through a lot of topic and spoke very eloquently. I couldn't have explained it like that. Radiation is a little more simple. So radiation is actually an X-ray. X-rays that go through the body and can cause damage at the DNA level in tumor cells that are rapidly multiplying. And so from one cancer cell to become 2, it has to make a copy of itself. It has to make a copy of its DNA and then split apart to make 2, and then make 4, and then make 8. And so that replication process, where the cancer cell becomes, it multiplies itself, the DNA has to be copied, and the radiation causes damage at the DNA level that prevents that cell from rapidly or multiplying and growing. And so radiation therapy, in the most common sense that we use the most, is an external radiation X-ray source that gets directed at a tumor, and it goes through the body and gives direct damage to the DNA of those tumor cells, which causes them to die. Radiation therapy comes in a lot of different flavors. The most common that I just mentioned is called external beam radiation, where radiation X-rays are generated from a really large machine, and it gets targeted and directed at a certain area in the body. If there's something called external radiation, so there must be something called internal, the opposite of that. And so internal radiation goes by the name of brachytherapy. Brachy in Latin means close, and so you bring the therapy in close to the patient. And so there are surgical procedures that can put devices inside the patient, inside a tumor, where the radiation can be given from the inside out versus from the outside in. And then lastly, there are actually radiation drugs that called radiopharmaceuticals. They can be given intravenously, where much like targeted therapy that Dr. Rahal mentioned, we can have a particle of radiation that emits radioactivity, and you can connect it to a molecule of your choosing. And that molecule can circulate through the body and park itself, is what I tell patients, where the tumor is located. And so a common one would be in the bone. So we have molecules that sort of look like calcium, and they take a radiation particle along for the ride. And they park themselves inside the bone and gives radiation off from the inside out. And so external beam radiation, internal brachytherapy, and radiopharmaceuticals are the big three for us.
Gotcha. That's a good explanation. One thing I think might be interesting for the community, or just at a high level, what do you guys see as the most common cancers that we see in our community?
I think the top three that we see are probably breast cancer, prostate cancer, and lung cancer, and maybe colon cancer would be the.
I agree.
if
I
you throw those
think
in
that's
there.
what we usually see the most common.
And in and around prevention, what do y'all recommend for prevention for like those significant community cancers?
Yeah, prevention's a huge part.
Yeah.
So we like to think of the cancer program. We're blessed and fortunate to be a part of it. We're just one little small piece. Cancer affects everybody, and all sorts of physicians are involved in the care of a cancer patient, from the primary care physician to all kinds of specialists to the oncologist to radiology, it touches everybody in the hospital system. And in the cancer center, we like to think of three sort of main components. The first being prevention and screening. The second would be treatment and dealing with the cancer. And the third is survivorship. So how do you live after a cancer diagnosis? But prevention and screening is a huge topic. And there are multiple cancers which have different screening protocols to try to catch the cancer at an early state. And that's a pretty big topic, but lung cancer, prostate cancer, breast cancer, everybody knows you get mammograms, you do colonoscopies, you do, now for lung cancer, you can do CT scans for patients who are at high risk, but catching the cancer early is a huge part of increasing a patient's chance of success.
I think I agree. I just want to clarify a few points. That's an excellent overview. Or just kind of from the community, people would like to know, hey, well, so when I should do those tests? I think from a mammogram's perspective, I would start usually at the age of 40. And how often to do them? Usually the standard is to do a mammogram every year. And there are different societies that recommend to do it every other year, but I think doing it every year is usually covered by insurance, and it's usually a peace of mind that if anything will grow within a year, you should be able to catch it in a good time. As Clint said, colonoscopy, I think we used to start at the age of 50. But now we're seeing much younger people that are just, being diagnosed with colon cancer, and they are only 30 years old or 35 years old without any family history. So that being said, now we're start screening at the age of 45. So when you're 45, I would just consider doing colonoscopy. Now, if someone in your family had a colon cancer, then you probably start at the age of 40. Or 10 years before when they were diagnosed. Let's say if your father was diagnosed at the age of 45, then you start at 35. Or you can do, or 40, probably it's the minimum. And then regarding the PSA, it's kind of a little bit of a tricky topic because initially there was a recommendation against doing a PSA because a lot of the times there was sometimes you might have a high PSA and then you will have to go and do a biopsy. So really there should be a very good discussion between the patients and their family members regarding the PSA, when to do it, and if you have a family member. So if you are African American or if you have a family member with prostate cancer, usually your risk is higher, and I do recommend considering doing that. And CT scan, I think we're doing it at the age of 50. I have to double check that, but you have to be smoking for more than 20 years. And then we will do a CT scan of the lungs. So right now, the screening options that we have a CT scan for lung cancer, we have mammogram for breast, colonoscopy, we have PSA for prostate cancer, and obviously we have pap smears for cervix cancer. That's for now. We don't really have any other. Sometimes patients will come to my office and say, well, I need a blood test to tell me if I do have cancer or not. We're not ready yet. We might get to the point that you will do a test and they will tell you if you have cancer or something, but not at this point.
I'm glad you brought that up. I have heard some folks talking about that that blood test. So do you feel like that's coming in the future sometime where you can get a blood test?
It could be. I think we're in a time where we're being able to kind of take the blood and check for the cancer DNA in the blood. So I feel like we're getting there. And there are a lot of companies out there, but we have to be very cautious because once you do that, it's very expensive. And a lot of the times they will bring those results to their primary care doctors. And it's hard for the PCP or the primary care doctors to be able to look at the results because there is no standard on how you should do, what you should do if you have something positive or not. So when you don't really have a standard way of analyzing a specific result, it's better not to do it at this point.
Gotcha. One thing I wanted to also just ask, maybe Dr. Rahal, you can help answer this a little bit. I know not just in Greenwood, but throughout the whole United States, perhaps the whole entire world, there's been a decrease in the age of onset of cancer. I've done a little bit of reading about this. I was just curious from your perspective, any insights into why that might be? Why are people getting cancer at younger ages?
Well, I think I might not be right, but I think when we talked at the beginning about the cancer, usually what happens with the cancer, you're born with normal genes, and the genes will function normal. So when people get cancer, there are three big categories why they can get cancer. One of them is age. As anything that ages after 80 or 90 years of working, that machine or something will get weaker and older, and eventually that gene, which is working every day for 80 or 70 years, it just get damaged and people get cancer. And that's what we said. Sometimes patients come to us, why did I get cancer? We tell them it's from age. The fact that you're more than 70 years, your risk of getting cancer is high. The other risk is genetic. You're sometimes born with a genetic mutation. There are some family members that have, for example, an example would be a BRCA mutation. A BRCA is BRCA mutation. If you're born with that mutation, your risk of getting breast cancer is 80%. So patients that have that mutation, they need to kind of have their both breasts removed and their ovaries removed. So, and the third one is what we call environmental things like smoking, alcohol use. But right now we're seeing a lot of patients that don't drink or smoke that still have cancer, and it's what we eat. I think it's in the diet. So a lot of things, in the diet basically will affect the microenvironment in your intestines. I think they did a study one time in places like so remotely, let's say in the Amazons or something, where people don't eat anything except, no medications or no fast food and nothing. And they looked at the microbiome, which is the actual bacteria inside your intestines. And they had millions of bacteria there, and they really never had that amount of cancer there because, they are protecting kind of, And if you think about it, right now, the availability of fast food, you start when you're 1 year old right now. But when someone now, I'm seeing 90 years old, they didn't have that availability of food when they were 10 or 5. They were probably started to get exposed to that amount when they were 40 and 50, and now we're seeing the cancers. But when you're starting at the age of 1, eating fast food, the rate of obesity has increased a lot. So when you're more obese, you're at high risk of developing breast cancer, liver cancer, and many other cancers. I think the social media and not being able to do exercise. So I think it's a big topic to go through. We'll probably take up of hours talking about it, but just to make it simple, it's what you eat, Exercise, we're exercising less, we're eating more food that is not appropriate, we're basically not doing, we're not maintaining a good body weight. In the past, people used to go work all day, not eat a lot, maintaining that good body weight, and you used to see less cancers. And another thing might be that now we're doing more screening, and that's why we're catching things. In the past, we didn't have that medical care that we have now. So right now, you're able to check more labs, more scans, and you're able to catch things sooner. Might be that.
Good, thanks for that. One of the things we touched on a little bit, Clint, I believe you were talking about like the number of different physicians that are involved in the care of a patient with cancer. Would you guys be okay just talking for a few minutes about what is our tumor board? Like, how does that process work? If someone's first diagnosed with a cancer and they're coming to our cancer center, just talk. I mean, to me, I love that we have this at Self Regional, and it's really, I think, how it should be. But maybe just talk a little bit about how tumor board works and how we make decisions on what's the best treatment for a patient, an individual patient, and their specific cancer.
Okay. So a tumor board in general is just a meeting of oncologists and other providers who are involved in cancer care. We get together and talk about specific cases. Sometimes it's by disease site, where we have a lung cancer tumor board, and that's all we talk about. We present all the new lung cancer patients. We have the oncologists, the radiation oncologists, the radiologists who interpret CT scans and PET scans. We have the pathologists who interpret the biopsies. We have the thoracic surgeon who does lung cancer operations. We have pulmonologists who are involved in lung care. We have support staff from genetics. We have nursing support, social work support, what's called tumor registry, who kind of keeps track of all the statistics of the cancers in our community. So it's a pretty big meeting that we have on a routine basis. Sometimes it's lung cancer, dedicated to that topic. Sometimes it's just breast cancer. We have a neuro-oncology, so brain tumor board, where the neurosurgeons participate. We have the breast surgeons who participate. So it involves a lot of different doctors. It really touches a lot of different places and different specialists. But we have a couple of tumor boards that we meet at least twice a week and discuss difficult cases. We sort of collaborate to bounce ideas off of each other to make sure we have the patient's best interest in mind, and we coordinate the sequencing of therapy, or sometimes we just don't know what to do. And there's cases that don't really fit the mold, and there's not a textbook for a certain situation. And so we rely on each other to kind of give some experience and to give some insight about how to deal with certain types of tumors. So tumor board's a really important thing. Most cancers across the cancer centers across the country will participate in tumor boards, and we've been really thrilled about having a tumor board for the last at least 9 or 10 years on a routine, frequent basis. And so we're looking for opportunities to expand that here to deal with other cancers that are also very common. Mm-hmm. The tumor board's a really integral part of what we do.
Yeah, 100%. I think there's a lot of people that just don't know about the tumor boards, that is even happening.
The patients love it.
Yeah.
When they hear that you're talking about them and they're the center of the attention,
yeah,
they think that's a really cool thing, and it is a cool thing. They want to know what is being said about them. They want to know, hey, what did the tumor board say about me? And so they think it's a neat thing. In the past, we used to participate with other institutions. We have a partnership with MUSC, and we used to bounce really difficult thoracic cases off of MUSC. In a what I call a virtual tumor board back then. So yeah, tumor boards are really a nice thing to do. It's a great opportunity to learn. They teach me things every day in tumor board, and we go through the patient's staging, their scans, and develop a plan of action for each patient. It's an individualized recommendation. Cancer is really not a one-size-fits-all kind of thing, and so the patients want to know, what are you going to do about my cancer? What's unique about my situation? How are you going to deal with it?
Exactly. That's what I love about tumor board, is exactly what you just said. And I've been to tumor boards with some of you guys when I was chief medical officer, and I'm just really impressed with exactly what you said. You've got 7 or 8 physician specialists in different specialties sitting around the room talking about an individual and their cancer and reviewing everything from the slide, the pathology, to the surgical plan, the radiation, the chemo plan, et cetera. It's really impressive to see it in action, and I appreciate what you guys are doing. It's a big deal for the community. So that's awesome. One other thing you mentioned, MUSC. Let's talk just for a minute a little bit. I know we participate in some clinical trials with MUSC. We have a partnership with them in that regard. You guys want to just touch on that a little bit and kind of how we are able to enroll some of our patients into some clinical trials that, even though we're not necessarily a research institute, but we partner with MUSC to get folks enrolled in some programs.
Yeah, so each of us has an appointment, we'll call it, with MUSC. We hold a faculty position on the staff of MUSC. We have a research partnership with them. They're sort of our the umbrella that we sort of fit underneath, and we can opening clinical trials is a huge process and tons of oversight, and it takes a lot of people to have an active research program. And so being a small center, we just don't have that kind of staffing to do it, but we're lucky that we can get underneath the MUSC umbrella, and we have access to everything they have access to. We can open any clinical trial that they have, and clinical trials is what pushes cancer care. And so I always tell my patients, back to basketball, it's like a basketball tournament. You have two teams and they play and the winner moves on. And that's how clinical trials work. You have two treatments and they get compared to each other and the best treatment moves forward, and that's how we get to where we are. And to keep pushing that to the forefront of the next available therapies, we have to keep doing more research. And so we're really lucky and thrilled to have an active research program here at Self. And I just randomized a patient to a clinical trial today, and these are national phase 3 randomized big clinical trials that you hear about in the news, and we're participating and putting patients on those trials every week. And actually, Self has been recognized in the past as a what's the right way to say it, but our participation has been such a high level that we've been nationally recognized as a small community center for the amount of research that we participate in. So we're really happy about it. We're really proud of what we do, and we think it offers new opportunities that are on the cutting edge for our patients here. And it's really awesome that we get to do that in a small center, to be doing things on a national level.
Well, I think that's key. We're a small center, but we're doing the same high-level care as you're going to get at a big giant cancer center in Charlotte or wherever. I mean, we're Atlanta, Greenville, whatnot. We do that right here, and it's so much more convenient for patients to get their care here at home. I think that's kind of one of the big messages I kind of want to get out there. We're not just like rinky-dink dabbling in cancer. I mean, we're all in our cancer center, and the team that you guys, you all and the team you guys work with are just phenomenal. So let's touch on just a little bit some of the accreditations that our cancer center has. If we could talk about that for just a second. So like our dedication to quality and outcomes and some of the processes we have in place.
So I think that's a very important topic, because you really need to know as a patient, if you're going to a specific center, you really need to know to a specific practice that has a specific standard that you feel like you want to be treated where some place that they give you a very high quality. The American Society of Clinical Oncology, they started a program, I believe, in 2010 called QOPI, QOPI, which is a Quality Oncology Practice Initiative. So the idea of that program is that basically they want to make sure that the oncology practices, they have a specific standard to be able to deliver the highest quality of care or cancer care. So that they usually, in order for a cancer center to be QOPI certified, they have to apply for that, and they need to maintain that certification every 3 years. And how it happens, there will be a specific team from the American Society of Clinical Oncology. They will come in and basically to the practice, doctors and nurses, and kind of look into specific benchmarks. And they do compare that nationally. So there's an average about more than 100 other practices, and you have to really be at least average or more to be able to qualify, and every 3 years they evaluate you in order to be that. So, and we're very, proud and then happy to say that Self Regional has been QOPI certified since 2012. And we are certified now until 2026. So I think last year, 2023, we were certified for another 3 years.
Awesome.
So if you're out in the community, and what is important for you to know that self-regional scope is certified is basically it's assuring you as a patient that we are committed to deliver the highest standard for cancer care by the American Society of Clinical Oncology, which is something really hard to have, because, and it's an important thing. So it doesn't really mean that it's because of one doctor or something. It's even harder than that. In order to maintain that qualification, that's a whole center. So you're talking about, they don't really look at the performance of a doctor. So you have to have nursing team, pharmacy team, infusion center, how they mix their chemo, what are their, the practices that they do to avoid any mistake, the patient research, data collection, all that. You really have to meet a lot of things to be able to get that certification. So it's not like a specific doctor will let you get that qualification. It's really much bigger than that. So, and it's really a long process when they go and review everything you do. And in order to maintain that qualification, it's really hard work. And I think as Clint said, it's really a teamwork. It's not really, cancer care is not really, it's not one person. It's really a lot of, it's a huge kind of dedicated team to work together in order to be able to get that care. Sometimes, the nurses in the infusion center, they will tell me, I don't feel the patient is doing well. Do you mind checking on them? And that's very important because, I think that's a teamwork. And we work together to be able to deliver the best care. Sometimes we kind of overlook something, and then the nurse will kind of look into it and then kind of touch base with me if I need to review something. Sometimes there's a pharmacy team. I sign the chemo orders. I might have that. Then there's someone behind me that will check, and those qualifications will make sure that we meet the highest quality standard and maintain that certification. So I think it's important to have that certification.
Absolutely. One of the things I often hear is around like the navigator. And I know in breast cancer, that's like a big deal. We have a close family friend who's going through breast cancer right now, and the relationship they've developed with their navigator is a big deal. Would you make one of y'all touch on that a little bit about how does that process work?
Well, I mean, we can both talk about it, but basically from our oncology standpoint, so the navigator is a patient advocate inside the center. So it's someone working for the patient. They kind of facilitate things for the patient. So you're inside, and then you come into the cancer center, you meet your doctors, and you meet your navigator. And then basically the first day they're talking to you, you have cancer. It's this stage, we're going to get scans, schedule you for chemo, you're going to do a biopsy, and you're not really thinking about anything. And then you go home and you really need to talk to someone in the cancer center, and then you pick up the phone, who do I need to call? So that person there is if like you are there. So anything you need, so what's next? Do you mind asking the doctors if they can do this for me? So they make sure that everything is on track, because sometimes we as doctors might get busy, and then that patient went to surgery and the pathology is back. The navigator will come and tell me, by the way, that's the pathology, just came back today. Do you mind looking at the pathology if we need to do something different? So this is really like having the patient eyes inside, taking care of, someone inside kind of to take care of them. It's very important. I don't know if you need to add something, but
yeah, I mean, cancer treatment is complicated, and like he said, it can be overwhelming, and they just need somebody who's looking out for them, somebody they can phone at any time who knows their story, and can be a helping hand, put an arm around them, and guide them through this process. He nailed it. I mean, they're really there to advocate for the patient and to be a first contact. They play an integral role between different specialties. So as we mentioned before, a lot of different specialties can be involved in one patient's care, and this is the central person who can communicate and be a liaison between all the different specialties. And so we're happy to have several navigators. We have a breast cancer navigator. We have another navigator who's focused on lung cancer and head and neck cancer together. And we have another navigator who focuses on gastrointestinal tumors, so colon cancer, rectal cancer, anal cancer. And so these people are really critical to what we do.
Yeah, they're awesome, and I'll tell you, talk about dosing out the compassion. I think those folks really do that.
Right.
It's a special person that takes those roles very frequently. So one other question is around access. So like if you're first diagnosed by your primary care doctor, for example, with something doesn't look right on your CT or whatnot, and they think it may be cancer, and you get a referral into the cancer center, like walk me through that process. How long does that take, and like what would be expected from that situation?
Honestly, I feel like what we have here is unique. I mean, there might be other cancer centers, but I think sometimes being in a small community really works for the patients. Because, I think the access that they have here is phenomenal. I can potentially guarantee you that we're able to see any new cancer patient the same day, if needed. We just add it to the clinic. Sometimes I go to Dr. Wood, I'm like, I have this new patient and they will need chemo radiation. And do you mind seeing him today? I barely remind one time when he told me no or something like that. So, and the same thing, he comes in and I have this patient, we need to start chemo radiation together. Can you see him? And he will have a busy clinic. I told him, just add him and we'll see him. So I think a lot of the times primary care doctors, they have my phone, or they can text me or call me through the operator, or they call the doctor. That we usually have a 24-hour doctor that is on call. So it's a physician on call, and then if their doctors, they find something and they don't really know what to do, they just call us, and then we guide them. We tell them, well, send the patient to the ER, or we'll see him tomorrow in the clinic. We bring him to the clinic and we'll take care of them. I had a patient, for example, I was going home and then I got a call from the operator the other day, and then it was one of the primary care physicians here in town. And one of the patients presented to them with pain in the left upper abdomen. And the patient felt something, and then they did an ultrasound. And their spleen was huge. It's usually 24, it usually should be about 4 inches, and it was about probably 8, double the size. And if it gets really big, it can rupture. And the doctor really didn't know what to do or what would be the next step. So I talked to him, and it was about 5 p.m., and I just told him, just let the patient come in tomorrow morning and check in. And we saw the patient, and we were able to diagnose her with a type of lymphoma and start treatment within a week. And then after 4 weeks, her spleen went back to normal size.
Awesome.
So I hear sometimes, in bigger cities, they're busy. You're busy. In order to get to the center, it takes about a week or two, and then to get scheduled with a specific doctor, it gets a month or two with surgery. And I think, here, I think we have an excellent access for the patients.
Yeah.
I would
that's
say that.
key too. You just are diagnosed with cancer. You don't want to wait a month. I mean, you want to get on it
know
right away.
now.
Yeah. Good.
Yeah, and we have the ability to do that. So people want to be seen, yesterday.
Right.
When you get that diagnosis, all you can think about is how am I going to deal with this?
Right.
And every day counts in their brains, in their hearts.
Yep.
So.
Good. I know we're doing some really cool, innovative special clinics at our cancer center, and maybe you guys can touch on a little bit. Clint, I'll start with you. I'm super excited about our stereotactic radiosurgery program that you have kind of put in place in conjunction with our neurosurgery team. Can you talk about that a little bit, and like what makes our program kind of unique in that space?
So let's just define what that is first. So stereotactic radiosurgery is a radiation treatment that is directed at brain tumors. And usually it's a metastatic brain tumor, a tumor that started elsewhere in the body and spread to the brain. And in years past, that was a very grim diagnosis. That meant your time was short, and there really wasn't a lot that you could do. But radiosurgery is just that. It's a radiation treatment that sort of acts like and takes the place of surgery. You can eliminate and totally kill a tumor, a cancer in the brain with this type of radiation. And so what sets radiosurgery apart from our typical radiation is the amount of radiation that we give, how focused and how intense and how concentrated the radiation can be. It's an enormous amount of radiation that can be squeezed into extremely tight spaces with accuracy that's better than a millimeter. So sub-millimeter accuracy of radiation being delivered to a target and able to avoid some critical part of the brain that may be directly adjacent to it. And so it typically is given in a single treatment, which takes about 30 minutes. It requires no anesthesia, there's no cutting, there's no needles, the patient isn't put to sleep. They don't feel anything. Nothing touches them. The radiation comes at them externally, and it points it at these small brain tumors. And we started this program about 5 years ago, and we've treated, hundreds of patients with this, and we've just seen amazing success. The patients tolerate it extremely well. It's a great alternative to having brain surgery. We have the cooperation of our neurosurgeons who are completely invested in this program with us and help us with all of our cases. In fact, both of us are present during these treatments. They help us design the radiation and help us follow the patients as they move forward. But it's a game changer for us. We've seen amazing success. When I walk through the waiting room and I see people sitting there who received this radiation 3, 4, 5 years ago, who at that time you would have told them, you probably won't make it 6 months. And to see them show up year after year after year, and they're doing great, and they're living their life, and they're enjoying things, and we can control these little brain tumors that pop up from time to time with this treatment that's extremely sophisticated but so well tolerated. It's just been really an amazing modality to be able to offer. We're really excited about the success we've had with it. And what sets our program apart, I think, from others is that it can be done quickly and it can be done rapidly. So other types of radiation exist that also do the same thing, but they take so much longer. Some of our other cancer centers in the upstate or in the lower part of the state will do the same thing, but it takes an hour or two. And they'll tell the patient, no, bring a CD, and you can listen to your CD while you're getting your radiation. In our hands, you can listen to 2 songs, and we're done. And so it's it's much more convenient. We have some patients who have actually come in to receive this treatment during their lunch break, and they go back to the factory or back to their employment after the treatment is over. And so it's a way of delivering extremely intense, very focused radiation to small areas of the brain to control brain tumors, which would have formerly been a lethal diagnosis.
Yeah, this is a game changer in my mind for metastatic disease in the brain.
Totally is.
Just
It's
completely.
amazing.
Oh my gosh. And thank you all for sharing that with me. I've got to see a few patients get treated with stereotactic radiosurgery, and it really is a painless process and very quick. I think that speaks a little bit to the Self Regional's investment in the cancer center, wanting to have that latest technology, that like machine, for example, that will deliver that. Do you want to talk about that for just a little bit?
Yeah, I'd be glad to. So the machine that we use, it's called a linear accelerator. The machine that we happen to use is a dedicated stereotactic driven machine. So it was built and designed specifically for these types of treatments. The accuracy that it can deliver, the ability to monitor the patient during the treatment and to make sure that absolutely no movement is seen in the patient is second to none. We were actually the first cancer center in this whole state to have this machine, and we've had it for 5 years. Yep. So we were way ahead of the curve. Other cancer centers are now kind of catching up to that, and I think it's remarkable that in our small community, the investment has been amazing to dedicate this sort of resources to this type of treatment that not many other people can claim that they have.
Yeah, absolutely. That's awesome.
It's amazing to have it, because sometimes we're treating patients and they like doing so well, except that they have a spot in the brain. Mm-hmm. So we talked with Dr. Wood. He goes in and he treats it, and then it can save the patient a lot. In the past, we used to treat them with a more kind of extensive radiation to the brain. So having that option for our patient is amazing.
Absolutely. And so we also have a few other programs that I thought maybe you could touch on real quick.
Sure.
We have a high-risk breast clinic and the cardio-oncology program, and any others that you want to mention.
Yeah, definitely. So let's start with the high-risk breast clinic. Mm-hmm. So usually we're all at risk of developing cancer. Women, they usually have a risk of 1 out of 8 lifetime risk developing breast cancer, so it's about 12%. So any woman, usually they have a risk of developing breast cancer by 12%. So there are some that have what we call the high risk. And what we define the high risk with is if your risk of developing breast cancer is more than 20% throughout your life. Once the risk is more than 20%, you're considered high risk. And who are the patients that are usually high risk? Usually those are patients that have family members. Let's say if you have more than one family member with breast cancer, so your risk of developing breast cancer is usually higher. If you have, for example, a specific kind of mutations in the family or specific kind of density of your breast might be a little bit more dense than some other woman, then your risk would be higher. So what does it mean? I mean, someone would tell me, okay, my risk is higher, and then what should I do? I mean, they start like, being anxious about that. So is there anything we can do about it? And that's what we call the high-risk breast cancer clinic. And this is kind of a specialized clinic just for those patients. So we basically go over why they are high risk. In order to know the risk, we have to run through calculators online and show them where did we get that number from. And then we go on to a specific program for that particular patient on what we can do to kind of do the best, to have the best outcome here. Mm-hmm. So again, it's a risk. So those patients might never develop breast cancer, right? So it's a 20% of developing breast cancer or more, but there's a much higher percent of not developing breast cancer. But our goal here is, number one, we implement a screening program. So the screening that usually any woman will get is, as we said, is a mammogram. So for patients that usually have a high risk, the recommendation is, in addition to do a mammogram every year, is to do an MRI. Because a lot of the times the MRI is able to detect cancers that are small enough that a mammogram wouldn't. Mm-hmm. And a lot of the times there are some breasts that are a little bit more thick or dense inside. That means they have a little bit of more fat tissue inside them. Mm-hmm. And in a regular mammogram, it can obscure small tumors. Mm-hmm. And doing that MRI, you should be able to detect them. And it would be very important because if, let's say, obviously no one wants to get cancer, but if you detect the cancer when it's very small, all you might need might be surgery and that's it. You might avoid chemo or sometimes radiation or sometimes any other medications. So that's number one. So we try to kind of catch it sooner than later doing that screening program. Number two would be kind of someone, if your risk is 20%, what can I do to reduce the risk? Mm-hmm. So we go over what we call lifestyle changes. So we talk about things that have shown that they kind of help reduce your risk. Exercise, so maintaining a good exercise, maintaining a normal body weight, and we talked about all the lifestyle changes that they can do. And we also have medications that can help them. Not every patient is a candidate for that, but that's why we have a clinic to go over all the details to see if those medications are options for them. We go over the side effects and we go over the benefits and the risks, and every patient is different. So I don't think there's a one size fits all. So some patients, they are more of an aggressive type and they want to try the medication and reduce the risks as much as possible. Some other patients, they focus more on trying to do the MRI and the mammogram and hold on doing any medications as long as they are able to catch it sooner than later. And the last thing is we usually send them for a genetic evaluation because those patients, they might have a mutation that might put them at a high risk. So usually the first visit we go over everything and then we just kind of make sure we watch them closely. And prevention or early detection is better than treatment. That's number one. That's one of the clinics that we have, high-risk breast clinic. So we're really very proud to have that clinic. And the other clinic is called a cardio oncology clinic. Cardio means heart and cancer, So this is kind of a new, nationally, it's a new program or a new clinic that not really, all the cancer centers are starting having it as an option. And we really were one of the, we really, from the beginning when that was an option, we really wanted to work on it. And we have been doing this for now 2 years, I think. So it's a coordination between the oncologist, the cancer doctors, and a cardiologist, which is a heart doctor. But the heart doctor kind of has trained specifically on cancer drugs. So there are some cancer drugs that cause damage to your heart. So, and nowadays, really, it's not all about giving the treatment. In order to maintain that high quality of care, you really need to maintain 100% success and avoid damage. So you want to win. You want to, in order to avoid that damage, the cardiologist will look at them and will see if they would be at a higher risk of developing heart damage from that drug. And sometimes they will prescribe medications to prevent that, or they will monitor them. And whenever we start seeing any potential damage to the heart, we can stop the drug or change to something that will avoid that. Because at the long run, you want to be free of cancer, but at the same time, you don't want to be free of cancer and having a heart problem that will kill you. Right. So what we're trying nowadays to kind of control damage as much as possible. Mm-hmm. Sometimes less is more. Our idea now is to try to be perfect in anything we can, trying to prevent and trying to monitor everything, and that's where the cardio oncology programs comes in. I'm not going to take much time, but I will try to talk about another program, which is called the exercise program, mm-hmm. which is the oncology exercise clinic. So right now we have a program which is a 12-week program that, specialized therapists, they will kind of help each patient. So each patient is different. So they will go and they the first visit, they will go over, their performance and what they need to do. And the idea of this program is to maintain a good physical activity. Some patients will come in and we will start chemo, for example, and I tell them we're going to go ahead and send you to that exercise program, and they will tell me, well, I'm fine, I'm able to do everything. Why should I do exercise? I tell them, you're fine now, but after about 3 or 4 months of chemo, your performance will go down. And if your performance go down, you're not able to get up and move around, and then we will not get really good results. So really, they kind of prepare you to avoid you from getting in a bad shape, and it's really a great program to have. And it has shown that it has improved survival. People do better, and if you're in a better shape, you're able to get up and move more, able to receive more treatments, and as long as you're keeping those treatments on track, and it's a combination. So cancer care is not anymore about just giving the drug and that's it. So 20% is the medication. You need really good spiritual care. You really need good exercise. You really need good, excellent team. Nurses, pharmacists, different kind of doctors that take care of that patient to be able to maintain that high success rate.
Mm-hmm. And we are so glad you guys are here to offer that here, you and the teams that we work with.
And that's amazing. Yeah, I mean, being able to get everything in one town, in one place, rather than traveling to some place. So we're very happy to have cardiologists that are specialized. We learn from them. And it also helps us to make sure that, there's someone that really knows and taking care of the patient, because we know when we treat our patients, it's like we're treating our family members. We want the best results. Mm-hmm. And you don't want someone that is free of cancer in 5 years, you hear that they have problems with their heart or something happens. So obviously things might happen at the end, but anything you can do to kind of prevent that, and when you're dealing with cancers, you have all those appointments. You don't want to really travel to get the care that you need. So if you have everything in one place, it really helps the patient kind of maintain that, maintain the appointments and being able to receive that care.
Yeah, absolutely. Guys, this has been awesome. I really appreciate you spending some time with me and with the community today, sharing some insights into our cancer center. Is there anything else you guys want to touch on before we wrap it up here today? Any other? If not, then
no.
Thank you guys so much.
Thanks for having us. Really.
Dr. Rahal, Dr. Wood, two of our phenomenal oncologists at Self Regional. And we'd love to thank you all for joining us for Medically Speaking today, and we look forward to the next episode. Thank you all.
Thank you.